catheter. Without tricep muscles, you cannot transfer in the bed, you cannot mobilize the wheelchair. So that's give the aspect we have to. The tetraplegia patients face many obstacles performing AD, such as feeding, dressing, and hygiene care. In a survey of male patients, 75% rated restoration of normal function of the hands are more important than bowel and bladder, legs, and sexual functions. So important for hand function in tetraplegia especially. It is not a surgery, tetraplegic hand surgery is not a new concept. It is 40 years back by AIIMS from the Sweden. They described about the muscle tendon unit transfer, which redistribute the remaining functional muscles to restore mainly required active elbow extension, knee grip, and finger grasping. This is main requirement for the tetraplegic rehabilitation. Keeping all this in aspect, today topics what we cover. These are the questions. This is we have to know during this 10-15 minutes classes. Who are the potential candidates for surgery? When should that surgery should be done? And what kind of surgery should be done? Either tendon transfer surgery or nerve transfer surgery. And what are the difference between this tendon transfer surgery and nerve transfer surgery? And how are the reconstruction helpful to these tetraplegic patients? The first question is, who are the potential candidates for the surgical point of view? Injury at level of C5 and 8, and there is some expandable donor muscles which get 4 or more. There should be one muscle should be, I will come across what are the muscles. And patient should be medically and psychologically stable, no active infection, no joint contracture or spasticity, full passive range of movement of joints and pain-free limb, and good caregiver and psychologically also patient should be strong enough to go for the surgery, because after surgery there is minimum 6 months rehabilitation, vigorous rehabilitation requires. So there should be psychologically patient should be prepared for that. Then a classical ideal candidate who is mostly benefited in the hand surgery is a C5-6 injury who cannot actively extend the elbow but has an active elbow flexion, and who cannot control the thumb for pinching but has active wrist extension, at least functioning brachioradialis muscle. In tetraplegia, for hand surgery, brachioradialis muscle is a key muscle. You see, throughout my lecture, always you listen brachioradialis, brachioradialis, and brachioradialis. Contraindication, some contraindication, like any surgery, we have a contraindication, uncontrolled spasticity, contractures, chronic pain problems, and psychological instability. There is a classification system to how to plan. Accordingly, classification system, we have 11 groups of the patients. It is classified as International Classification for Surgery of the Hand in Tetraplegia, ICSHT. Many persons can tell ICT also. ICT group 1, 2, 3, 4 like this. The ICT, accordingly we have to plan out which surgery we will do. I will not describe all the surgery. The typical part of the surgery needed, specifically major surgery, I will discuss something. The group 0, we will firstly follow about the classification. This is sensibility. This is the ocular type, this is the cutaneous type. As for the sensibility, how you classify sensibility in this tetraplegic hand? The 2-point discrimination at the tip of the fork of the thumb or index, there should be 10 mm. If more than 10 mm, it is ocular variety. If less than 10 mm, it is cutaneous variety. But you have to state group it like that. And 0, 1 is when there is a brachioradialis present. Why we are not taking SCI scale? Because SCI scale has some like C5, this is your flexion, C6, C7. C7 it covers one movement, but here you see this is C7, group 3, 4, 5, 6, 7, 8. These all groups are containing C7 injury. But muscles are separate. What are the muscles available to us? So, for the surgical point of view, their muscle, what are the muscles should be available to us? We should know that. That's why classification system, they do all the groups. First is brachioradialis. If there is extensor brachioradialis longus is present, along with brachioradialis, along with all these things, extensor brachioradialis brevis is present, group 3, then pronator is present, group 4, flexor brachioradialis is present, 5, extensor digitorum communis is present, 6, then extensor pollicis, partial division, and last X is the exception. Many times there is a variability of this. Maybe brachioradial is not there, some is not there, and something is there. That is X type, X group. Accordingly, we have to plan for the surgical management. Then next question: what should the surgery be done? When should the surgery be done? Ideally, when there is a plateau of recovery. If there is a complete spinal cord injury in cervical level, most probably after 6 months we think there is a plateau. We will not think about more recovery. Or if there is partial, we can up to wait to 18 months. I would say. So approximately 12 to 18 months is the ideal time. Generally around we can do that. And if after that, any time you can do, there is no time limit. If after 3 years also patient come to you with deficit of hand function, he wants my hand should be worked and I should do the ADL properly, then you can plan in that time also. After 3 years. So there is no time limit for the tendon transfer. Only thing is when you transfer the nerve, then if there is a lower motor neuron type of nerve, then you have to think there should be a time limit. There should not be, before transferring, there should not be atrophy of the tendons. If there is atrophy of tendon, this is you cannot transfer the nerve. So in lower motor neuron type, you have to transfer before nearly 18 months, which is the atrophy. And upper motor not required, time limit is not there. You can transfer a nerve anytime. Then, what are the surgical procedures available in hand? One is tendon transfer, mostly focused today. Tenodesis, it helps when there is no muscles. We can anchor the tendon with the bone. For that, when we do the agonist, suppose our flexor pollicis wants to pinch, but there is no muscle. What we will do? The flexor pollicis longus we attach to the distal part of the radius. We fix it, cut it and fix it. When we move the wrist in the dorsiflexor, then this finger will automatically touch to the this. This will help. That is the tenodesis effect. And sometimes we have to do the arthrodesis, osteotomy, nerve transfer. This is not today's class for you. So we will mostly focus on the tendon transfer. So what kind of tendon transfer surgery is done? The most important target functions are elbow extension is important for overhead activity. I told already, weight transfer, wheelchair propulsion, and to enable more control of the hand. And restoring E-grip makes it possible for the patient to do safe intermittent catheterization. For that, we mainly need key functions: active elbow extension, E-grip by thumb pinching, finger grasping. Elbow extension reconstruction. How will do? I will tell just the procedures. You may not completely remember all the things, but you just focus on the salient features. The patient with C5-6 injury, what happened? Here shoulder control, C5 is there, and elbow flexion C5, bicep brachialis and deltoid is there. Cannot actively extend elbow because it is by the C7. So here possibility of a surgery, you can transfer the posterior part of the deltoid. It is posterior part of the deltoid. You isolate here. Remove from this insertion. Take one part of the deltoid out and release it and attach to the tricep posteriorly. You can do that. Otherwise, you can take the tibialis anterior muscle in the foot, because in tetraplegia, each in-house sitting in the wheelchair. You can take the tibialis anterior and loop around in the posterior deltoid and fix to the All process along with your tricep. But it will help the tricep muscles. It gives around 3-4 powers for the elbow. Next, now recently most are following bicep to tricep transfer. What will it is easy to do? Nothing, just around the elbow. You have to take the bicep here and just turn it down that side and fix it the tricep. It is easy to do, easy also to follow on the all purpose of rehabilitation. So these two surgeries we can do it in the for the elbow extension. Post-op care, after surgery, there is a long post-op care. We have to long arm cast with elbow in no more than 20 degree flexion. We have to give 4 weeks POP cast. Shoulders will be 30-degree abduction. After cast removal, give an inch orthosis around the elbow. And every week, 15 degree flexion restriction should be there, and extension is free. And always use soft split for the tendon to avoid the tendon rupture, which will transfer. Then wrist extension. Wrist extension only in the class 1, means stage 1 cases, where there is a bacteroides. Next, up to class 2, class 3, class 4, bacteroides is there, extensor carpogadialis longus is there, so extensor is there. So in class 1, you can go for the wrist extension. Here we take out the brachioradialis. Brachioradialis fits with the extensor carpogadialis brevis to gain the wrist extension. Next surgery is knee grip reconstruction. What we do in knee reconstruction? You can do in two types. One is active knee grip, another is passive knee grip. In active knee grip, where patient are functioning wrist extensor, but no functioning flexor pollicis longus, then available brachioradialis can be transferred to the flexor pollicis longus. Means here what happens? Here this is after the group 2. The classification group 2, brachioradialis is there, extensor carpogadialis brevis is there. So you have to take out this brachioradialis and directly go to the volar aspect and stitch with the flexor pollicis longus and hold in the in between. You make a hole and take this brachioradialis muscles and take the tension. When you feel that it is opposite, or the thumb is coming closer to the index finger, like a pinch grab, then you tie it reversely and stitch it. So it makes a pinch grip. Then next, passive grip. When there is no extension available, then you have to shift brachioradialis to the dorsum of the brachioradialis to the extensor carpogadialis muscle to stitch it, and the flexor pollicis longus to make a hole in the distal radius and fix it. It will act as a tenodesis effect. This is the passive grip. Post-operative program, you have to arm immobilize for 2 weeks in 90-degree elbow flexion, 20-degree wrist extension, flexion and thumb and index MCT joints. Then following removal, you have to apply the dorsal split in wrist in 20-degree extension. Then palmar grafts reconstruction. Next is the palmar graft reconstruction. It can be done either 2 stages or 1 stage. We have mainly 3 surgeries in tetraplegic hand. One is the tricep, another is the finger pinch, another is the grafts. The 3 palmar graft reconstruction 2-stage procedure, where the surgical procedure for restoration of the finger flexion and extension are performed 2 to 6 months apart, depending on wound healing and how supple the tendon transfer. Within first we have to prepare for the extensor tendon, then after 6 months flexor tendon. This is the extensor phase reconstruction. Here this is extensor digitorum communis EPL passively by the tenodesis and transfer of the EPL. It is too complicated, but remember the extensor muscle will transfer first. Next, post-operative we have to give 3 to 4 weeks POP cast, followed by sprinting, re-education. After 6 months, start the flexor group of motion, flexor phase of treatment, where the extensor carpio is previous. Have to intermingle all the 4 slips of the flexor digital and profundus. It will help for the flexion of the fingers. But this is the second phase. Posture management, like arm, you have to keep always in the 3 to 4 weeks in flex position at 90-degree elbow flexion. Cast removal, always use the speed as much as possible to 6 months, otherwise it will damage whatever we are transferring the tendons. One stage lateral pinch and palmar gaps we can do at a time when there is a group 5, above 5, pronator trace is there. If pronator trace is there, we can go for the at a time both the things, lateral pinch and palmar gaps, and along with CMC arthrodesis, FPL split transfer, EPL, all procedures at a time as a single go. Postoperative therapy is started on the first postoperative day and continued for another 3 weeks. Then this is the as per classification our goal. IC muscle level, what I showed in before, international classification of the tetraplegic hand, 1, 2, 3, 4, 5. As per that, what in group, what we expect, what are our goals should be there, and we will achieve that by with muscle transfer. Then newly concept developed. This is the recent concept. Previously they are doing the tendon transfer in tetraplegic hand. Now developed nerve transfer. How to give the function, but there is not much literature now available now. But this is the possibility. Posterior deltoid branch of axillary nerve can transfer to tricep branch. Here brachialis branch of the musculotendinous nerve can transfer to etiologius nerve, and supinator branch of radial nerve can transfer to posterior etiologius nerve. This is the graphical scene when we are going for the elbow extension. If tendon transfer, we are doing tendon transfer, bicep and posterior deltoid can be transferred to the tricep. For wrist extension, brachioradialis can be transferred for the extensor brachioradialis pelvis. Simultaneously, thumb and finger flexion, you can go for the FPL tenodosis, brachioradialis to FPL, ECIL to FDP. And finger extension, EPL to EDC tenodosis. In nerve transfer, accordingly, if you want elbow extension, posterior deltoid and teres minor branch or brachialis, any branch to the tricep branch. If wrist extension you want, brachialis branch of musculotendinous to ECIL. This is the advance now they are gaining popularity. So what are the difference between tendon and nerve transfer? This is the next question. If we do tendon transfer and nerve transfer, what is the difference? Principle is tendon transfer reroute functioning expandable muscle tendon unit, where nerve transfer re-innervate or target muscle using expandable donor nerve out of the injury area. Timing of surgery, there is no limitation. In nerve, there should be before 18 months. Stage surgery, separate stage flexor extension is possible, but can be single stage surgery.
2 minutes.
2 minutes.
Then how are reconstruction helpful? I search a literature also, many of the times here more than 70% of participants during this surgery were generally satisfied with the results. Another literature showed 75% accurate with ICC, intermittent clean catheterization with significant improvement of urinary status. Elbow extension increase up to 3 power 3 after transfer of the muscles, and there is a limited literature for the nerve transfer, so I cannot tell exactly what we can do, but tendon transfer is definitely helpful for the tetraplegic hand surgery. Conclusion: the surgery is typically muscle tendon unit transfer surgery, which can redistribute the remaining function and muscle for better active elbow extension if you can finger grafting. Recent emergence of nerve transfer is showing promising results, but not literature supportive. A motivated patient with good social support along with coordinated multidisciplinary management will bring rewarding results. Good. Thank you. Take home message for tetraplegic hand. Imagine first you see the brachioradialis is there or not. If brachioradialis is there,